Hello and welcome everyone to tonight's Just Ask from the European Academy of Osseointegration. Tonight, it's an amazing pleasure for me because I have one of the total rock stars of dentistry with me, which is Professor Tomas Linkevicius. Tomas, you were my dream candidate for that series here, and I'm more than happy that you agreed to do with me this session. And so, just with this, I would like to introduce you. I think you're a rock star in dentistry. You're world famous. You're a professor in Lithuania. You're actually a prosthodontist, which is very nice because we can discuss all the different topics. And you're quite famous and well-known, lecture international for your zero bone loss concept. Thomas, it's a great pleasure to have you tonight. Thanks for accepting the invitation. Thanks for accepting the invitation. Thanks for accepting the invitation.
Thank you for the invitation, of course.
Thomas, you might have to switch off YouTube. At the same time, if this is possible. 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 So again, welcome back. We had a small technical issue, but now we are back on track. I'm not sure everyone has got the introduction. I do it a little more quickly. Thomas, great to have you. I already said you're a rock star in dentistry. You're world famous for your zero bone loss concept. Again, welcome to tonight's show.
Yeah. Thank you. That was my technical problem. I forgot to switch off the YouTube from the other channel. So now we are clear. Thank you for invitation. EAO has a special place in my heart. Actually, this association was the first which invited me to speak in 2010, I think it was in Glasgow. So I was very, very happy that you asked me to talk about I think very simple but very important topic. Okay. How deep placing implants and why we need to place them subcrestally and what's all prosthetics about. So I'm really excited to get all the questions and ready to start.
Yeah, thank you, Thomas. It's great, and you know it's an interactive format what we have here, and I actually want to thank you for doing one thing because. I was always the soft tissue surgeon on all these lecture podiums, and always they told me, you're doing all these soft tissue surgery because of aesthetics. And then came your study, Thomas, and that brought me more to heaven because now people told me, okay, he's doing all these soft tissue surgeries also because of a biologic reason. So thank you also for implementing that into dentistry. Thomas, I knew that I have you as an expert tonight, and a case came across me yesterday. And I thought, man, I'm going to have Tomas Linkevicius tonight in the show. How would he restore this case? So just as a quick introduction, give us your two sentences. So I have two implants here, flat-to-flat connection, slightly placed supracrestally, I think good soft tissue situation. So, Thomas, what should I write on the sheet for the lab technician? What would you say?
So I would say that, to properly really give you an answer, I would need X-rays. but certainly then you have the balance between X-rays and the clinical picture. But definitely, I would say that needs to be restored with polished zirconia crowns. And depending on the connection, I am not sure what kind of implant it is. So probably I would also ask the lab to connect them to avoid future possible screw loosening. But that's prosthodontist talking in me.
Yeah, but this is
So,
interesting, Thomas. Let's come back to that. Would that only account for a flat-to-flat connection, or would you also splint implants with a conical connection?
so I would say that, of course, the connection type also depends on prosthetic stability. In other words, if you have flat to flat, the steeper the connection, the more conical it is, the more stable it is, and the less likely you would need have screw loosening. However, from the other hand, we have also, splinting comes with a price. Then, sometimes some connections are more difficult to splint. You need multi-units. So I always say, simple questions are not answered very simply because there are a lot of ifs, and what about this, what about this? So I said that, you start to answer the questions like it depends.
Well, that's a very, very good answer for that. And that's actually because of these many ifs, we have you here tonight. And Thomas, already a lot of people logged in. We have people from Libya, we have people from Russia, from Serbia, Turkey, Lebanon, Oman. So welcome and hello to everyone all around the world. And now, actually, we want to have your knowledge, Thomas. So I know that you prepared maybe 15 minutes of lecture to give us a little bit of backbone. And as you're used to it, we'll just discuss, Thomas and me, and we will also integrate your question. So please use it. You have the true expert here. Type in your question, and I will hand them over to Thomas. And with this, Thomas, we would love to hear your presentation.
Okay, and just think, if you think like any question, you can interrupt me. It's not like I'm on the podium. It's more like a discussion, as you said. So,
I definitely will.
Yeah. Okay, let's do that. Great. So welcome everybody. Thanks for logging in, and again, thanks for invitation. And I would like to really briefly summarize the key important things about why should we start placing implants subcrestally? Another question, what implants should be placed subcrestally? Because I start from the beginning, not all implants can be placed subcrestally. And of course, the last, is there anything we should know about restoration of subcrestally placed implants? Because, yeah, it's a different thing. And I like this picture, I always show it during the lectures. You see nicely subcrestally placed implant about 2 millimeters below the bone. And now the question arises, okay, can we do it? What should be used for doing it? And then how we restore it? Because you have not only the bone around your implant, you have bone above your implant. I call this the channel of the bone. And then it really has contact, with your prosthetics. Similar with immediate, really, I learned lecturing through many years that a lot of clinicians, don't feel comfortable seeing pictures like this, when the implant is deep and you have a lot of tissues around and, will it integrate? What will happen? So all those questions are really valid, and, maybe our meeting will answer some of them. Because from my point of view, I would say that placing subcrestally implants has really saved me a lot of complications. And I really have only good experience, like you see here on these two nicely X-rays, when you see bone growing all around the connection. So subcrestally placed implant, if the bone grows above the connection, it also strengthens the connection as well. It's really is more stable. So I would say that you even have some more bone growth with subcrestally placed implants, if of course you do them right. Now, why we should be placing implants subcrestally? And here I want to show really the study which I took the inspiration from my study, 1996, Berlin and Linde. They were the first to say that vertical tissue is really important factor for crestal bone stability. And if you don't have enough, doesn't matter what you do, you will lose bone. And as I said, that was true inspiration for me. So 2009, this study which you mentioned, it's still a secret to me why this study became so popular. You know, I just did it out of my curiosity, you know. We paid for all the implants out of our pocket, so no funding at all. And it study really proved and showed that indeed, if you have thin tissues, you have bone loss. And if you have thicker tissues, you can have not bone loss, but even bone improvement. And you see the last X-ray here, it's the image, the same image from the study 15 years after, and you see what the bone is doing. Like, this is regular connection, it's no platinum switching, but look at the bone.
Thomas, what I always wanted to ask you when I look at your study, is there also, and I also get these questions many times, is there also too much tissue thickness? And did you have cases where it was way more than 3.5 to 4 millimeter? And did you see a detrimental effect?
Actually, a very good question, because all the study here, which I did 2009 with my colleagues, was a delayed study. It means there were not immediate. And what happens when you extract the tooth in molar regions, premolars, the tissues shrink approximately to 2 millimeters. So you actually very seldomly find something above 3. It also differs to the country, to the probably phenotype. In Lithuania, we do not really have a lot of thick tissue patients, so there is always some shrinkage of the tissues. But let me go back to the question, because your question is really connected to prosthetic part. So please remind me when we'll talk about prosthetics, because then I will answer. I mean, is there too much tissues? Okay.
Yeah.
We really, in my opinion, it really glues together. Then, so those studies really showed that if you have 2 or less millimeters, you have bone loss. But with time, I learned that, you know, you need to also have a clear number. So we know what is bad, but what is good, what is sufficient thickness. And here, a lot of inspiration was done from this Cristiano Tomasi study when he took biopsies of implants without bone loss and showed that he have about 3.6 millimeters of tissue thickness. And it all comes back to the first study. Remember when we talked about that, you know, what is thin? So we know that it's 2 millimeters, but in the same Berlin study, they said that the implants which did not have bone loss had about 4 millimeters of tissue thickness. So that's actually my reference mark. And I do this in immediates and delayed. If you have 4 millimeters of tissues, then your bone stability is secured from this point of view. Of course, you have additional parameters you need to think about, but at least if you have 4, actually 3.6, but to be more exact, more easy for clinical, I always say 4. That's my reference. And that's what I also calculate when I do immediate from free gingival margin. My implant is located at least 4 millimeters from pre-gingival margin. Now, how does this science influence our...
Thomas, that was a very good question, which I like very much, because this connects to it. If you place it subcrestally, do you add the millimeter which you place the implant subcrestally to your soft tissue compartment?
So, for example, this is a good case. Like here you have 2 millimeters of tissue thickness. I would today, because this is an old image, you see here bone loss, I would take the implant and place it 2 millimeters below the bone. So 2 millimeters of tissue, original tissue thickness, 2 millimeters below the bone, because you will see that the tissue will grow and will increase by those 2 millimeters. So you have 4 by placing implant deeper.
So
Now,
you sort of adjust that you lose a millimeter of bone and add soft tissue by this?
it's not always you will see, not always you lose bone.
Yeah.
Sometimes you still have the channel of the bone, and the tissue does not always resorb that bone. It just grows and the bone stays, and you will see it just
it supports it.
Yeah, it goes like, and just very, 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 very thin, not visible on X-ray. And why you sometimes have bone resorption, and that also depends probably on the patient, because in some patients, you see, I call this, you sacrifice the bone above the implant, not to lose bone below the implant.
Yeah.
But sometimes even that is not happening. And I'll show you this some cases. Schematically, it looks like this. Imagine these are thin tissues, and if I'm placing implant subcrestally, like here, so the tissues just will grow and touch the neck of the implant, and that's why you have less bone loss in subcrestally placed implants compared if the tissues are thin and if the implant is placed at the level of the bone. So here, I will say maybe a controversial thing, but I truly believe it is. The name of bone level implant is really a bad name because it dictates subconsciously, especially for young clinicians. If you ask how you place bone level implant, they will answer at the level of the bone. But actually, you sometimes need to place it deeper if you have thin tissues. So that's the thing which I understood by talking to many clinicians. And if you place bone level at the level of the bone with thin tissues, you're gonna end up with bone loss like you see here on the screen.
What would be the option, Thomas, if I say, okay, it's a bone level implant, I place it bone level and augment the soft tissues 1 millimeter in height?
Yeah. So you are free to do that. And actually, that is one of the ways I do, because not always you can submerge the implant. Not always you can subcrestally. There is anatomical limitations, correct? Then you place at the level of the bone. And as you said, you put on top. You take soft tissue graft or substitutes, depending on your preference. And you augment not only horizontally, because we're used to augment tissues horizontally, but you can augment vertically. And then, it's possible to do it as well. It's possible to combine as well. You place 1 millimeter subcrestally and add 1 millimeter of soft tissue graft, and you have 4 millimeters, and then your implant will be really secure without having any bone loss. But why I'm talking about subcrestal implant placement, because for me, it's most easy, and it's most easy for many clinicians. And remember when you said that, you always sacrifice the bone, not always. Take a look at this X-rays. You see implant subcrestally and bone above. And here, what you see on the video is just thin layer. Actually, this is biological width. Thin layer connective tissue which grows without resorbing the bone and just touches the implant. So I think this is really an easy way to get rid of this bone loss. Now, that's just one clinical case, like I now probably, like many of us, when you see old clinical cases, you say, now I would do it differently. So the same, I would do it a little bit differently now, but here you can see really lack of vertical tissue thickness is obvious just by looking at this clinical image. And still, if I have bone and I have implant which is possible to be placed restally, and I will just discuss what kind of implant that must be. So you place the implant deeper, you have here this deeper 2 millimeters, and you see in this case we will have some bone remodeling or bone loss above the neck of the implant, but that really does not influence the final outcome. Here you see the bone resorbed a little bit, but now I do not have any bone loss. And again, if I would just place implant at the level of the bone without augmentations, I would have bone loss, and then it would be different story. So that's why subcrestal implant placement is the most easy way to get rid of thin, soft tissues. And in extraction, when you have extraction of the teeth in the molar regions, usually tissues shrink to 2 millimeters. So any way to get 4, you need to end up with certain procedure. Now, the second question I want to talk about, can all implants be placed subcrestally? And that's the tricky one, because not all. And sometimes if you choose the wrong implant, you can end up in more damage than good by placing implant deeper. Now, what do I mean by that? So for example, here you have the implant with flat to flat 45-degree connection. And you see first image, second image, third image. And just by placing implant deeper, I have bone loss. Even I compensated tissue thickness. Now the implant is deeper. But why do I have bone loss? And if I switch to another scenario, again, different implant design, and implant is placed the same subcrestally, and look at the bone. Just improvement, right? No bone loss, no any reaction, although both implants really are placed 2 millimeters subcrestally. So that's, again, another part of zero bone loss concept, is that you need to understand what implant you are using.
Thomas, is that because of platform switching, or is that because of a more stable connection? I mean, the science is not clear on that. What is your take?
Both. I think what science, not science, but clinicians are wrong, and a lot of lecturers are wrong when they start and say, now this is the most important factor. I think the most important factor does not exist. Because according to my studies, I should say that only tissue thickness is important, then it doesn't matter. You have 4 and you always have bone stability. That's not true. If I would take 4 millimeters tissue thickness, and I would place, for example, this implant in the middle, you see here, again, this is internal connection, 45 degrees, which is not stable, I would lose bone. And it doesn't matter had the tissues are 4 millimeters. So that's why it's combination of more factors. And I would say that platform switching and connection stability are equally important. So we are going again to the definition what implants should be used. So I think that implants with conical connections can be placed subcrestally. If you have external connection, or if you have flat to flat, or if you have 45-degree connection. So you see, this is the image of famous study when they looked at the movement. Now imagine this is going on 2 millimeters below the bone.
Sure.
Of course, you have bacteria going out, and movement itself is harmful. Even if we would theoretically have sterile situation, movement itself will be harmful. So my suggestion, based again on the studies which I did, just to show a couple of them. So here we used implants with 7 degrees conical connection, which is really stable, and we had only 0.18 millimeters of bone loss after a couple of years. Now, in another study, we used implants with 12 degrees connection, and look, we had also only minor amount of bone loss, and also bone getting better with time. Like this is at the restoration time. This is 1 year follow-up. You see remineralization. So connection stability is really, really important. And from the other side, we did studies with the implants, which connection is good for level of the bone or above the bone, but not good for subcrestal position. And we had completely different outcome, that if the implant without stable connection is placed about 2 millimeters subcrestally, you have more bone loss if you would just leave it at the level of the bone. So as I said, it is really combined like you need think that subcrestal placement is okay, but what kind of implant I am using.
Thomas,
And
from
that's
your perspective, just one question, because there's also been a discussion, or we have seen data that subcrestally placed implants might also be a risk factor for peri-implantitis in perio patients. Do you see this, or is that also just one piece just drawn out of this whole puzzle?
I completely disagree. I strongly disagree with this, that subcrestally placed implants have any risk to develop implantitis, because, as you mentioned, like if there are studies which show this, you need to inspect what kind of implants were placed subcrestally. Maybe they used internal connection, and bone loss is not,
or the buccal bone was too thin.
Yeah, or also prosthetics. So for me, subcrestally placed implants is very linked together with how we restore them. And if we are not choosing the appropriate prosthetic material, so then you also can have the problem. So as I said, not just placing implant deeper, you must restore that implant accordingly. And that will be the last part of my discussion, what prosthetic things. But generally, I just came up with this, how to say, the recipe, and you can choose according your implants which you're using. So how to make that our subcrestal implants would be successful. So stable connection, the most open connection, I would say it's 20 degrees. If it's up to 20, you still can be placed subcrestally, platform switching, and no vertical smooth surface. So for implant which is placed subcrestally. So if you follow
what do you mean
this,
vertical, like the shoulder shouldn't be machined?
Yes. I think again this is misconception and placing implant.
Totally. I never understood that.
I mean, you place, you have bone loss, and now you say, oh, it's great, now it's smooth surface, but you are the one who created it. So
I have never understood the concept of placing a machined shoulder on a bone level type implant.
Exactly. I'm with you here. I mean, for me, it's crazy. I mean, and then with the bone level implant with smooth surface, simply you cannot place it correctly. It's impossible because platform switching and conical connection dictates that you should be placing deeper, but smooth surface resorbs the bone.
Right.
So it's I'm here completely with you. So that would be my recipe for implant, how to get crestal bone stability of subcrestally placed implants. And again, finally, again, to your, really this image goes to the question you asked, okay, what if this implant is like this? So this is one of my first immediate implants placed many years ago. I didn't have primary stability, so I had to place it deep enough, probably not the best design as I see it after many years. But this is really successful situation. And if you look again at this picture, it's very interesting that the canine is this implant restored. But what if you take a look at all the other teeth, that all they are surrounded with plaque except this particular implant. So in my courses, I ask the question that why is that? Is the patient cleaning just this the tooth which restored the implant, or does not care about the other
Maybe
teeth?
it was so expensive, Thomas.
Exactly, as I said. So when people pay, they tend to value it more, right, than to get free. Like we get our tea for free, right? So
I don't know how expensive you were 15 years ago.
Oh no, 15 years ago, I was very not expensive. Well, anyway, so those cases tend me to think, okay, is there a big difference in the material we're choosing? And I believe, and it's not the belief, we have 6 studies on zirconia and different methods. I think that the polished zirconia is really a material. It's the best for subcrestally placed, generally for all the implants, but especially for subcrestally placed implants. And why? Because you have much more better soft tissue adhesion to the smooth zirconia compared to any other material. And it's not about connective tissue, it's also about epithelial adhesion, because our protective cell is actually not connective tissue. Our protective cell is epithelium, which glues to the surface. So this is so important, and a lot of clinicians tend to forget about this. That connective tissue, of course, it's great, but if you don't have a good epithelial adhesion, then you have pocket. So if I have good epithelial attachment, adhesion, I have no pocket. And I want to show you this couple of cases. It's amazing what zirconia can do. So this is 5 years follow-up, and you look at soft tissue growth. I still cannot explain it like, scientifically, but what I see is a lot of soft tissue improvement without any connective tissue graft.
But Thomas, let's be honest. Also, I mean, the good bone level plays here a role, probably.
Of course. So those are the cases with subcrestally placed implants. That's the point. It's a combination of everything. But I did not really observe this with, for example, porcelain or metal fused to the porcelain or zirconia porcelain. So my favorite case, this one, restored, and then patient came for connective tissue grafting, and I see picture like this. So now you don't need grafting. But to really, how to say, explain this, this is a very nice video from our group. When you see two different zones, actually, this shows why vertical tissue thickness is important. And it also shows why prosthetic material is important, because you have adherence. And if you look now, we are removing abutment, and you see the glue, like the hemidesmosomes are still, gluing. It means that is how actually protection of soft tissue is occurring. So zirconia is really, I think, really key factor to have bone stability around subcrestally placed implants as well. So my recipe would be, I'm not using any other materials, polished zirconia for many years.
Thomas, I have one question. I had Peter Gerke here last time. I don't know if you've seen it maybe. And I always ask the same question, because for me, it's quite interesting. What are you doing? Are you rather using a very flat tie base and then immediately start with polished zirconia? Or should I use a maybe 1.5, 2 millimeter tie base and then start a little later with this polished zirconia? What's your take? You get my question?
Your question is so good, because I just couple of last slides straightly answering to your question.
Oh, sorry.
Yeah, I mean, this is so good. We didn't really, didn't prepare this, it's just, so you are right. I mean, the T-base selection for subcrestally placed implants is much more important than in bone level. Like here, you see this case, like subcrestally placed implant, and wrong tie base can destroy the implant. I mean, you have perimplantitis compression. So how to avoid this? Now, this
Sorry,
is one
Thomas,
of
this is so interesting. Go back one more time. You think it's only the tie base, or it's the form of the tie base?
Of course, because you see, it is also wider than the implant.
Right. So, but I could start with zirconia subcrestally. That's not a problem, right? But
yeah,
but it's the form.
The form. I mean, so this is how I mean, you can also by the X-ray understand that this is actually a third-party tie base, not original, because tie bases should never be larger than the diameter of the implant. So they should be align. So here is, I'm just thinking how the patient was suffering, right? If you torque it like, and like, so, yeah, and
It
the
was
pressure.
full anesthesia, I think, for seating the crown.
That's hope, right? Because another point, you cannot, what I observed with time, that patients react to pressure differently, because, and then you cannot really contain it.
Yeah.
For some patients, the pressure spreads, and then you have huge bone loss. Some patients, don't react like this. They just feel, okay, it's a little bit painful, but I'm fine. So, but my point is not really to go into that at all. And this is one of, actually, I'm going to show, I'm really excited to show one of the innovations which I worked on, like this year. As we talked before the conference, I'm not lecturing, I'm not flying, but I'm staying at home, so I'm working. And one of the ways is to use this tool. I call this T-base detector. And you can see here these lines, right? So this is my height of tie bases. And I retain it, I can make an X-ray, and I can show to the lab, and lab can select according to the level of the bone. And for example, as you said, this would be very flat, 0.6. This is 1.5 higher. And let me show you this case. Like intuitively, we see here that we would want to select something like this, right? Because this is too high, maybe this is too low. And initially, this is what I did. I selected 1.5 millimeter tie base, and you see zirconia going away right here. So we have metal and then titanium and zirconia. But the selection of tie base should not be just based on the bone. You should also look at the tissues. And for example, here, the higher tie base resulted that I was not able to develop sufficient pressure to the tissues.
Yeah.
So it was foot trap. So the patient returned and said, look, I'm having foot impaction, and the same here. So I remade the prosthesis, and then I had to select a lower tie base in order that I would have about 3 millimeters of the tissues having contact with zirconia. So it's not only about bone, it's also you must calculate contact of zirconia to the tissues. And I would never...
But in an ideal world, what would be your favorite? Would you rather have a longer tie base in the very subcrestal area, or rather quickly go into zirconia?
I would say that, again, it depends.
I know.
But if it's about, let's say, 2 millimeters subcrestally, so I would say that you can get about 1.5 millimeter tie base and then zirconia.
Yeah. Okay.
But if you have, for example, deeper, right, then you need maybe to raise the margin of tie base.
Get it.
But to come back here, you see, I had to redo, and I had to make a lower tie base because I needed really more contact of the tissues to prosthesis. So I, again, do not agree with the idea that all tie bases must be at least 2 millimeters high. That is not true. It depends on the implant placement depth, and it depends on tissues and how much of the contact you want. But at least you can have some reference points when you can, again, talk to the lab. So in summary, for prosthetic part, I would say that subcrestally placed implants need more knowledge to restore. And you need to select different heights of tie bases. So I always send the X-rays to the lab. My lab never makes me a crown without seeing where the bone is. And now with this tool, I can also give them more information. So for me, I mean, it's probably like a really clear recipe how I'm going to restore. And really to finalize all the lecture, I would say that, yes, we should place implants subcrestally because it solves soft tissue thickness problem. However, we must select what kind of implants we are placing that should have conical connection and stable, and afterwards, preferable zirconia material for the restoration.
Thomas,
So all I wanted to briefly show you today.
amazing. That was amazing. You have such amazing stuff. Congratulations to your work, to your scientific work, also paired with your clinical expertise. I am one of your first row fans. If you ever give a rock concert, I'll be in the first row. So thank you very much. It was amazing, Thomas.
Sure.
Thomas, we have so many people from all around the world. They're applauding for your lecture. You can read it later from Costa Rica, from Greece, Philippines. We have several questions which I thought are interesting. Some of the questions are already added to you. There's one question which I thought is interesting. What about one abutment, one time? Old story. Does it play a role? Does it not play a role? What's your take?
So does audience see the screen? I mean, because actually one of the studies which I showed, I quoted, if I quickly go back. Yeah, this one. So in this study, we compared exactly implant level restorations with abutment level restoration. So one abutment one time and with 3 disconnections. And at the delivery stage, we had more bone loss around implant level restorations, meaning the disconnection for subcrestally placed implants really causes some bone loss. But interestingly, after 1 year, once connection is stabilized and nothing's happening, you see here on the graph, right? You have remineralization. So the bone really came back, and after 1 year, there was no statistical difference. So this is my take that if you place implant subcrestally, one abutment one time gives you short-term advantage, which later will disappear. But of course, there is also prosthetic, what we need to discuss. In other words, if I'm placing 6 implants subcrestally full arch, I'm doing one abutment one time with multi-units. But that because of prosthetic need, right? But technically, if we would talk about single implants, I don't see long-term advantage of one abutment one time.
And that would be my next question. I mean, not only in full arch cases, but there are groups also working this in single cases, like using a mesostructure and then just working on that mesostructure. What do you think about that?
I think it's over complicating, but again, that's my personal opinion.
I think the same.
Yeah, because
you have 2 connections suddenly, right?
Exactly. You need to, it's multi-unit, it's like a new implant. You need everything.
We're on the same page.
So you must, I always say, you must really then believe and you must really trust the science. I would never switch like doing all cases with one abutment one time, because simply there is no such advantage. And, one of my studies, which I did really also, just confirm that, and your long follows up also show that. Also, additionally, you talk about small screws of multi-units.
Yeah.
So that's
short screws.
Yes, yeah. So I mean, this is for me, it's not a game changer.
Get your point. There's another question. By the way, everyone is applauding to your lecture, which I like the question. What about angulated screw channels? I mean, we all the companies, they do commercial about 30 degrees angle. Does it make a difference on stability? What is your take? I think a very good question.
Yeah, my take again is based on science. We have some unpublished data where we compared screw loosening in molar regions with angulated and straight screws. And with angulated screws, you had more prosthetic failures regarding screw loosening and breaking compared to the long, like straight screw. So what I want to say that it's only for anterior. I would say that would never use angulated screw in posterior region, but maybe that's also logical. But it's also, you know, it's very fragile. It's very, you know, sometimes if the axis of anterior implant is way off, I would go back and do cemented restoration with cleanable margins. Then I do angulated screw retained crown with angulated channel. So it's again depending on situation, but I'm not always in my portfolio.
Thomas, there are so many questions coming in. I get crazy. I've never had so many questions, but I think it's just a great topic. I just picked some of the questions we had. Huh?
We're gonna do part number 2.
That's what I said. You're gonna come back after your sabbatical. I just picked 2 or 3 more questions. I think a great question is that if you would do a soft tissue, a tissue level implant, how would you restore it? I like that question.
Yeah, that's one of the ways why I don't like tissue level implants, because it dictates me my restorative margin.
But if you would use it, what would you do?
Would use it. So you know what is the choice? First of all, I would place it where the rough surface begins with smooth surface, machine surface. Would not place machine surface in the bone, not to cause bone loss, because it is bone loss. We can call it remodeling for softer word, but it is bone loss. Then probably I would do soft tissue augmentation, because you would really need 3-4 millimeters of tissues. And then I would do screw retained crown on top of my tissue level implant. And the neck of tissue level implant would be something like my tie base. But what I'm not fan of tissue level implants, because as I said, then I have reduction of zirconia. So I would say that for good soft tissue adhesion, you need 3 millimeters of zirconia. Well, I do not have a science for that yet, but it's like, you know, clinical feeling, and all my research actually started from clinical feeling. So I consider clinical feeling of every clinician in very high regard, because that's the start of the science when you see something, right? And but yeah, I would restore it like this, like I described.
Thomas, there's one more question. I think we should clarify that. I think we already alluded to it, but I think we should really clarify it. There's a question concerning the zirconia in a subcrestal part, like saying we use a very low titanium base and we start with zirconia subcrestally.
Yes.
Would you
something like
this, correct, on the mesial aspect? Yeah. Would you prepare the zirconia different, like in a soft tissue part? It's an interesting question.
So my all subgingival zirconia is super polished.
Yeah.
So on top, what goes out of the soft tissues can be glazed, can be emax, can be whatever we like, but subgingivally it must be super polished. And again, the idea is why? Because zirconia does not attract the plaque. Zirconia is a smoothest surface. And once we understand that in protection from bacteria, which is actually coming not from the implant, but coming from oral environment, soft tissue adhesion, which is a product of epithelial hemidesmus molds. So for zirconia, the smoother the surface, for epithelium, the smoother the surface, the better. Yeah. So you see here, like my clinical case, like with low tie base with 0.8 millimeters and all zirconia super smooth. And you see that after 1 year, I have no bone loss, I have bone growth. And that is really the example how correctly placed implant subcrestally with correct design. This is 5 degrees conical connection implant, and super polished zirconia can influence the behavior of the bone.
Thomas, I think the question is even more specific. In that part where the zirconia is subcrestally.
Yes, it is the same as.
I understand, but let's make it very specific.
Yeah. Okay, it's the same.
Yeah. Okay. Great. Oh my God, there's so many questions coming in. So let's do maybe 2 more questions because I mean, come on, you're having your year off, and now I'm nailing you here with questions.
I missed that. Come on, I missed that.
The question a little bit is, which I also liked, is maybe just a little bit philosophical. Turka is asking that question. What do you think about all of these old parallel screws, machine types, working quite well over many years? It's a little bit more philosophical. Is that, in your opinion, today the worst approach than comparing it to a subcrestally placed implant with a conical connection?
It's difficult to compare because, well, we don't have 50 years of subcrestally placed implants with conical connections. But I always say that, first of all, we need to, define what success is. What do we define as well working? I mean, if the implant is present in the mouth, right? So that's one. If the implant has bone loss or no bone loss. So first of all, what is the level of success? What we define as a success? And I think that dentistry, I mean, implant dentistry has really grown so fast and so good in terms also of immediate implant placement, myself including, like, some years ago, I was against immediate. I was doing more, talking about like ITI type, everything slow, one time, one miracle at a time. Now I see that more advantage of immediate, and in immediate implant, and also patients demanded. So the trend shifted, and with this parallel non-aggressive implants, which were developed in the beginning, because all beginnings are like that, careful, step by step. It's not possible really to do immediate. And immediate implants is again one of huge things which benefits so many people. So for me, I had no privilege actually to work, in the beginning of implant dentistry with all the implants. I can just say that these type of implants you see here on X-ray placed correctly, I know how to make them successful. Does it mean only this works? Of course not, but
I get your point. I think you're right. Very good. Thomas, I think one more question. And the last question is a question from my side. My question is a little bit not to the material, but to the design and the angle of the restoration. We've been discussing about 30 degrees being maybe a risk factor for peri-implantitis. How do you construct the angle? And we have people like Oscar Gonzalez saying he starts very concave, and then in this superficial area gets convex. I know it's a very complex topic, but just your 50 cents on that.
I would say that, again, first of all, the most important factor for bone stability simply does not exist. When we start from this, then saying, that only shape like this, only like 35 degrees, and if it's 36, it's already bad. Come on, this is more factors there are in play. And doesn't mean that they are not controllable. Saying too much factors is the same as saying the only one factor, because when we say so many factors, it means that we somehow cannot explain bone loss or bone growth. I would say here that it depends, first of all, on implant placement depth, because all those studies which I showed in the past, at that time when we were working, there was no tie basis at all. All our contours were going steep like this. And those cases have zero bone loss, and they have like bone growth with time. So the deeper implant goes, and if the channel of the bone is untouched, because sometimes you can profile, right, and open up the channel. So let's say I place the implant, then my profile, yeah, should go like this. But if I profile the bone, I can go steeper. So again, we come back to that, the best word we like, it depends.
Okay. Tomas, that was amazing. Thank you very much for doing this with me, for doing this for the EAO. It was such a pleasure. I learned so much. I'm a surgeon, and I learned so much about pros. Actually, I already learned a lot from you. So thank you from the side of the EAO. Thank you from my side. People are applauding you in the channel. Sorry, people, if I didn't address all the questions. I think they can also reach you via social media and whatever. Tomas, thank you very much. It was a great pleasure having you. Thank you.
Thank you. And thank you for invitation. As I said, EAO is always special place in my heart, because that society was the first really to invite me, to acknowledge, and then everything was much easier for me.
Yeah.
Thank you
and
so much.
Saying EAO, let me just do a little bit of commercial for our annual congress. It's going to be in Milano in 25 and 26 of October. So there's still an early bird rate. So subscribe to the Congress. We all see you there. We're not going to see Tomas because he's not traveling. So stay at home, Tomas. And with this, I would like to thank you again, say hello and ciao all around the world. And Tomas, actually, you told me that we're going to do a part 2. So you're not going to get out of this.
Okay, no, I'm the man of my word. So I always
Ciao, ciao. Good night to everyone. Ciao.
Okay. Bye-bye, everybody. Bye.